You're listening to Who Said, a cardiology board review series. No fluff, just facts.
Hello, everyone, and welcome. I am very excited to be launching the second season of this cardiology board review series. In this episode, we'll talk about atrial fibrillation. We'll cover the terminology of key terms, rate control, rhythm control, amiodarone and dronedarone, and digoxin in this part 1 episode. In the subsequent part 2 episode, we'll cover electrical cardioversion, bleeding and stroke risk estimation, left atrial appendage occlusion, ablation, and lifestyle measures. So let's jump right into the terminology. Categorizing AFib. Paroxysmal AFib refers to AFib that is intermittent and terminates within 7 days of onset. Persistent AFib refers to AFib that is continuous and sustains for more than 7 days and requires intervention. According to the 2023 AHA guidelines, patients with persistent AFib whom, with therapy, become paroxysmal should still be defined as persistent, as this reflects their original pattern and is more useful to predict outcomes and define substrate. Long-standing persistent AFib is AFib that is continuous for more than 1 year in duration. Permanent AFib is when the patient and clinician have made a joint decision to stop further attempts to restore and/or maintain sinus rhythm. Acceptance of AFib represents a therapeutic decision and does not represent an inherent pathophysiological attribute of AFib. Subclinical AFib refers to AFib identified in individuals who do not have symptoms attributable to AFib and in whom there are no previous ECGs documenting AFib. This includes asymptomatic AFib identified by implanted devices such as pacemakers, defibrillators, or ILRs, implantable loop recorders, or identified by wearable monitors such as the Apple Watch or Cardia device. Which terms are being retired? Chronic AFib is a historical term that has had variable definitions and which was deprecated in the 2023 AFib guidelines. Lone atrial fibrillation is another historical term that referred to AFib without clinical or echo evidence of cardiac disease, including any hypertension in less than 60-year-olds. Lone AFib has also been deprecated in the 2023 AFib guidelines. What is aberrance? Aberrance means there is a functional block in a portion of the conduction system because you've hit a refractory period at high heart rates. For example, you can get transient right bundle branch block at high heart rates that will recover at low heart rates. In most people, the right bundle branch fatigues earlier. In 20% of people, the left bundle branch fatigues earlier. Now let's delve into rate control. What are the doses for acute treatment of AFib? For metoprolol, it's 5 milligrams IV metoprolol over 2 minutes, up to 3 times every 5 minutes. And you quickly follow that with PO metoprolol 25 to 50 milligrams once because the IV wears off rapidly. Then for maintenance, you do metoprolol tartrate 25 to 100 milligrams BID to QID. For diltiazem, you'd use IV diltiazem 0.25 mg per kg over 2 minutes, and you may repeat it every 15 minutes. You then quickly follow the diltiazem with a drip, 5 to 15 milligrams per hour, titrated to a heart rate less than 100. For maintenance, you can give diltiazem 120 to 360 milligrams per day in divided doses. For amiodarone, you give the standard IV bolus of 150 milligrams over 10 minutes, then IV 1 milligram per minute times 6 minutes, then IV 0.5 milligrams per minute times 18 hours. Then you transition to an oral load such as 400 milligrams PO Q8 hours for a 10-gram total load over the next 7 to 10 days before stepping down to outpatient maintenance dose. For digoxin, the dose is IV or PO 0.5 milligrams followed by IV or PO 0.25 milligrams Q6 hours times 2 for a total load of 1 to 1.5 milligrams in 24 hours in divided doses. Then you follow that with a daily dose of either 0.0625 or 0.125 or 0.25 milligrams daily. The most common dose is 0.125 daily. What do the 2023 AHA, ACC, HRS, AFib guidelines say about acute rate control? In patients with AFib with rapid ventricular response who are hemodynamically stable, beta blockers or non-dihydrodipyridine calcium channel blockers such as verapamil or diltiazem provided EF is more than 40%, are recommended for acute rate control. That's a class 1 recommendation. In patients with AFib with rapid ventricular response and known moderate or severe LV systolic dysfunction with or without decompensated heart failure, intravenous non-dihydropyridine calcium channel blockers should not be administered. That's class 3 recommendation, harm. In patients with AFib with rapid ventricular response in whom beta blockers and non dihydropyridine calcium channel blockers are ineffective or contraindicated, digoxin can be considered for acute rate control either alone or in combination with the aforementioned agents. Class 2A. In patients with AFib with rapid ventricular response, the addition of intravenous magnesium to standard rate control measures is reasonable to achieve and maintain rate control. Class 2A. In patients with AFib with rapid ventricular response who are critically ill and or in decompensated heart failure in whom beta blockers and non-dihydropyridine calcium channel blockers are ineffective or contraindicated, intravenous amiodarone may be considered for acute rate control. Class 2B. You should consider the risk of cardioversion and stroke when using amiodarone as a rate control agent. A conundrum is what should you do if AFib with RVR occurs in septic shock, where you're already hypotensive and already stuck with pressors? First, look to see if there's any new hemodynamic compromise on top of the baseline hypotension requiring pressors. DCCV or electrical cardioversion, if the AFib with RVR is causing new hypotension above the baseline hypotension. If the hypertension or pressor requirement already pre-existed and the AFib with RVR is not causing worse hypotension or increasing pressure requirements, you can hold off on electrical cardioversion. Second, check if there are any offending drugs. If norepinephrine, dopamine, or epinephrine are being used for vasopressors, try to change to vasopressin or phenylephrine, which are less arrhythmogenic. Discontinue beta agonists and other AFib offending drugs if possible. Third, check if there are reversible inciting factors. Correct electrolytes, correct ventricular dysynchrony, check for myocardial ischemia, optimize volume status, and treat underlying infection. Fourth, figure out, are the adverse effects of AFib in this critically ill patient mainly due to elevated heart rate? If so, consider esmolol drip non-dihydropyridine calcium channel blocker or digoxin. Are the adverse effects of AFib mainly due to loss of atrial systole or rate control is ineffective? If so, consider magnesium and or amiodarone. Now, how about long-term rate control? The AFFIRM trial showed that there was no difference in mortality or stroke between rate and rhythm control, but less hospitalization with rate control. Based on the AFFIRM trial, a target rest heart rate of less than 80 beats per minute was recommended, but the RACE2 trial showed that it was non-inferior to target heart rate less than 110 beats per minute, as long as there was no AFib symptoms and no heart failure. Therefore, the guidelines for many years, and again in the 2023 guidelines, have said in patients with AFib without heart failure who are candidates for select rate control strategies, a heart rate target should be guided by underlying patient symptoms, in general, aiming at a resting heart rate of less than 100 to 110 beats per minute. That's a class 2A recommendation. In terms of long-term control, rhythm control and rate control are given pretty much even footing in the most recent 2023 AFib guidelines. They instead recommend a shared decision making with the patient about election for rhythm versus rate control. Factors that favor rhythm control are younger age, short history of AFib, higher symptom burden, smaller left atrium, more left ventricular dysfunction, more AV regurgitation, difficult to control heart rate, or if the patient prefers rhythm control. On the other hand, factors that favor rate control are older age, long history of AFib, lower symptom burden, larger left atrium, less left ventricular dysfunction, less AV regurgitation, easy to control heart rate, or if the patient prefers rate control. What do the 2023 AFib guidelines say about long-term rate control? In patients with AFib, beta blockers or non-dihydropyridine calcium channel blockers such as diltiazem or verapamil are recommended for long-term rate control with the choice of agent according to underlying substrate and comorbid conditions. That's a class 1 recommendation. For patients with AFib in whom measuring serum digoxin levels is indicated, it is reasonable to target levels less than 1.2 nanograms per milliliter. That's a class 2A recommendation. In patients with AFib and heart failure symptoms, digoxin is a reasonable long-term rate control agent in combination with other rate control agents or as monotherapy if other agents are not preferred, not tolerated, or contraindicated. Class 2A. In patients with AFib and LVEF less than 40%, non-dihydropyridine calcium channel blocking drugs should not be administered given their potential to exacerbate heart failure. Class 3 harm. In patients with permanent AFib who have risk factors for cardiovascular events, dronedarone should not be used for long-term rate control. Class 3 harm. What is the objective of heart rate control in AFib? It really differs depending on the presentation. If the presentation is symptomatic AFib, the goal is to reduce symptoms. If the presentation is tachycardia-induced cardiomyopathy, the goal of heart rate control is to improve heart function or reduce the risk of recurrent cardiomyopathy. If the presentation is ICD shock, the goal of heart rate control is to reduce the risk of inappropriate shock. If the presentation is cardiac resynchronization therapy use, the goal is to enhance the percent of biventricular pacing, likelihood of myocardial recovery, and or preservation of function. If the presentation is tachycardia bradycardia form of sick sinus syndrome among those with a pacemaker, the goal of rate control is to reduce the risk of hospitalization. Now let's move on to the rhythm control agents. Remember what the class 1A, B, and C agents are. A are quinidine, procainamide, and disopyramide. B are lidocaine and mexiletine. C are propafenone and flecainide. 1A and 1B don't work for AFib, but 1C does. Lidocaine, which is a 1B agent, has no role in treating atrial fibrillation, as it mainly works in the ventricular areas. Let's go over the appropriateness and contraindications of rhythm control agents. Flecainide, which is 1C, and propafenone, which is 1C, can only be given if there is no CAD, no heart failure, and no left ventricular hypertrophy. So that's the strictest one. If there's HFrEF without CAD, you can still give amiodarone, which is class 3, or dofetilide, which is class 3. If there is CAD without HFrEF, you can still give sotalol, which is class 3, dronedarone, which is class 3, amiodarone, which is class 3, or dofetilide, which is class 3. If there is CAD and HFrEF, you can give amiodarone, which is class 3. If there's LV hypertrophy, you can give dronedarone, which is class 3, as long as there is no HFrEF. You can give amiodarone as well as if there is HFrEF. The only options for rhythm control for AFib in systolic heart failure are amiodarone and dofetilide. Due to its negative inotropic effects and proarrhythmic effects, flecainide should be avoided in patients with systolic heart failure. Due to its negative inotropy, sotalol should be avoided in patients with systolic heart failure. Dronedarone increases mortality in systolic heart failure and should be avoided in HFrEF as well. AFib occurring in patients with CAD, as long as there is no systolic heart failure, can get sotalol, dronedarone, dofetilide, or amiodarone, but they cannot get flecainide or propafenone because flecainide and propafenone will increase mortality in patients with CAD. In AFib, in hypertrophic cardiomyopathy, rhythm control agents preferred are amiodarone or disopyramide. You must avoid flecainide and propafenone in hypertrophic cardiomyopathy, just as you must avoid flecainide and propafenone in CAD. Hypertrophic cardiomyopathy counts as structural heart disease in AFib world. In AFib world, the term structural heart disease is extremely broad. It doesn't refer to just the structural interventions that interventionalists do on valvular heart disease, but pretty much almost any kind of heart disease, including HFrEF or CAD or HCM, counts as structural heart disease. Dofetilide and sotalol should not be used if there is severe LV hypertrophy with wall thickness more than 1.5 centimeters. Sotalol should be used cautiously in patients with reduced contractile function because of its negative inotropic effect, which may further decline the cardiac index, and precipitate heart failure. What do the guidelines say about rhythm control? According to the 2023 ACC-AHA-HRS guideline for the diagnosis and management of atrial fibrillation, in patients with reduced LV function and persistent or high burden AFib, a trial of rhythm control should be recommended to evaluate whether AFib is contributing to the reduced LV function. That is a class 1 recommendation. In patients with symptomatic AFib, rhythm control can be useful to improve symptoms, class 2A. In patients with a recent diagnosis of AFib less than 1 year, rhythm control can be useful to reduce hospitalizations, stroke, and mortality, class 2A. In patients with AFib and heart failure, rhythm control can be useful for improving symptoms and improving outcomes, such as mortality and hospitalizations for heart failure and ischemia, class 2A. In patients with AFib, rhythm control strategies can be useful to reduce the likelihood of AFib progression, class 2A. In patients with AFib where symptoms associated with AFib are uncertain, a trial of rhythm control, such as cardioversion or pharmacologic therapy, may be useful to determine what, if any, symptoms are attributable to AFib, class 2B. In patients with AFib, rhythm control strategies may be useful to reduce the likelihood of development of dementia or worsening cardiac structural abnormalities, class 2B. Now let's talk about the effect of these antiarrhythmic medications on the QRS duration and QT interval. Class 1A prolongs both QRS and QT. Class 1B shortens QT and doesn't affect QRS. Class 1B significantly prolongs QRS and slightly prolongs QT. Normally, as heart rate quickens, the QT interval should shorten. If a patient who is on a 1A antiarrhythmic such as procainamide exhibits prolongation of the QT interval greater than 10 milliseconds during exercise, that is predictive of a proarrhythmic effect. When you do exercise testing on patients taking flecainide or propafenone, which are the 1C agents, you should pay attention not just to the shortening QT interval, but also whether there is QRS widening during exercise. If there is QRS widening during exercise while on propafenone or flecainide, that is predictive of a proarrhythmic effect as well and reentrant ventricular tachycardia. Since procainamide is a 1A agent, it can prolong the QRS duration at therapeutic concentrations and prolong the QT interval with rising serum concentrations, precipitating ventricular arrhythmias. Sotalol, a class 3 agent used to treat AFib, blocks the inward rectifying potassium channel, prolonging the QT interval. Given these effects on QT, what do the 2023 AFib guidelines say about inpatient initiation of antiarrhythmic agents? Patients with AFib who are initiating, increasing the dose of, or reinitiating dofetilide therapy should be admitted for a minimum of 3 days to a facility that can provide continuous electrocardiographic monitoring, calculations of creatinine clearance, and cardiac resuscitation given the potential for proarrhythmia. That is a class 1 recommendation. In patients with AFib, it is reasonable to initiate sotalol therapy in a facility that can provide continuous electrocardiographic monitoring, calculations of creatinine clearance, and cardiac resuscitation, given the potential for arrhythmia, for proarrhythmia and bradycardia. That's a class 2A recommendation. So for dofetilide is class 1 to make them stay inpatient for 3 days, and for sotalol is a class 2A. It's slightly weaker. In patients with AFib who are initiating PITP dosing of flecainide, PITP meaning pill in the pocket, and propafenone with concomitant atrioventricular nodal blocking drugs, it is reasonable to receive the first dose in a facility that can provide continuous electrocardiographic monitoring given the potential for proarrhythmia. That's a class 2A recommendation. Now, what is reverse use dependence and use dependence? Reverse use dependence means a medication works better at low heart rate. This is a property of the class 3 agents, dofetilide and sotalol. Therefore, sotalol and dofetilide are more useful as a daily standing medication for maintenance of sinus rhythm. As heart rate slows, QT lengthens, and as heart rate quickens, QT shortens. In contrast, use dependence medications work better at high heart rate. This is a property of the class 1C agents, such as flecainide or propafenone, and less commonly with the class 1A agents, quinidine or procainamide. Therefore, flecainide and propafenone are useful as a PRN medication to take as pill in the pocket when AFib with RVR occurs. Again, these are the 1C agents that are useful for AFib pill in the pocket, flecainide and propafenone, due to use dependence. They work at higher heart rate. We just, in my opinion, should just rename use dependence to heart rate dependence to make it easier for everyone to understand. Flecainide is also effective in treating triggered PVCs in a structurally normal heart. Flecainide, which is a class 1C agent, blocks sodium channels, prolongs depolarization, and slows conduction in the atrioventricular node. Profound sinus bradycardia can be induced by flecainide in patients with pre-existing sinus node disease. You must start a calcium channel blocker or beta blocker at least 30 minutes before you give a class 1C pill in the pocket agent such as flecainide or propafenone. Regarding pharmacologic cardioversion with these agents, the 2023 AFib guidelines say, for patients with AFib, pharmacologic cardioversion is reasonable as an alternative to electrical cardioversion for those who are hemodynamically stable or in situations when electrical cardioversion is preferred but cannot be performed. That's a class 2A recommendation. For patients with AFib, ebutylide is reasonable for pharmacologic cardioversion for patients without depressed LV function, LVEF less than 40%, class 2A. For patients with AFib, intravenous amiodarone is reasonable for pharmacologic cardioversion, although time to cardioversion is generally longer than with other agents, 8 to 12 hours, class 2A. For patients with recurrent AFib occurring outside the setting of a hospital, the pill in the pocket (PITP) approach with a single oral dose of flecainide or propafenone with a concomitant atrioventricular nodal blocking agent is reasonable for pharmacologic cardioversion if previously tested in a monitored setting, class 2A. For patients with AFib, use of intravenous procainamide may be considered for pharmacologic cardioversion when other intravenous agents are contraindicated or not preferred, class 2B. Here are some other details that I just wanted to give you before we move on to the next section. If a Wolff-Parkinson-White syndrome patient has atrial fibrillation, you need to quickly give IV procainamide or IV ebutylide to prevent deterioration to ventricular fibrillation. Beta blockers, calcium channel blockers, and even amiodarone will precipitate ventricular fibrillation in WPW patients by causing preferential conduction along the accessory pathway. Electrical cardioversion is reserved for if the WPW patient in AFib is hemodynamically unstable. Antiarrhythmic drugs for rhythm control, such as sotalol, should not be continued or do not need to be continued when AFib becomes permanent. Antiarrhythmics such as amiodarone and disopyramide are unlikely to be successful in hyperthyroid states. Instead, you have to give PTU or MMZ and propranolol. If an AFib patient who has been using propafenone PRN for years comes in with syncope, in addition to discontinuing the propafenone, you need to do a 30-day event monitor to assess for sinus pauses and other signs of sinus node dysfunction after discontinuing the propafenone. Both propafenone and flecainide can exacerbate underlying conduction system disease, unmasking sinus node dysfunction, atrioventricular block, or infrahisian block. Prolongations in the PR and QRS intervals of less than 25% over baseline values are commonly seen with the use of these drugs. It is possible for sinus node dysfunction to gradually progress over many years to the point that it becomes eventually symptomatic when using propafenone. Again, if this occurs, you need to do a 30-day event monitor and consider pacemaker implantation. Chronic use of procainamide leads to development of positive anti-nuclear antibody in almost all patients, but only 20% of patients develop symptoms of drug-induced lupus, such as arthritis, arthralgias, and pleuritis. These patients will have positive anti-histone antibodies. Anti-ANA levels may remain elevated for years. The syndrome resolves within days to weeks of discontinuation of procainamide. That's what I wanted to tell you about the rhythm control agents. Now we will talk about amiodarone and dronabinol, which has both rate control and rhythm control properties. The onset of action of IV amiodarone is 1 to 2 hours, whereas the onset of action of PO amiodarone is days to weeks, but may be shortened to hours by large loading doses. Amiodarone's elimination half-life is multiphasic, with an initial 50% reduction in plasma concentration 3 to 10 days after drug cessation, followed by a terminal half-life ranging from 26 to 107 days with a mean of 53 days. Dronedarone is contraindicated in patients with class 3 or 4 heart failure and heart failure decompensation. Co-administration of dronedarone or amiodarone with digoxin requires a dose reduction in digoxin because dronedarone and amiodarone are potent inhibitors of P-glycoprotein and will substantially increase digoxin levels, causing digoxin toxicity. Corneal deposits, visualized by slit exam, occur in almost all patients who are treated with amiodarone for more than 6 months, but it is unusual for there to be any resulting visual impairment. Now we'll move on to digoxin. Digoxin controls rest heart rate but does not control exercise-related heart rate rise well. Other than the famed yellow color vision, non-arrhythmia manifestations of acute digoxin toxicity are nausea and vomiting, abdominal pain, potentially mesenteric ischemia, confusion, weakness, fatigue, hyperkalemia, not hypokalemia, heart block, and ventricular arrhythmias. Chronic digoxin toxicity, compared to acute digoxin toxicity, has less GI symptoms and more neurologic and visual symptoms. So chronic digoxin toxicity will have more lethargy, fatigue, delirium, confusion, disorientation, weakness, scotomas, and blindness. In terms of arrhythmia manifestations of digoxin toxicity, the classic sign is bidirectional ventricular tachycardia. Other than bidirectional ventricular tachycardia, other arrhythmias that can be caused by digitalis excess are bradyarrhythmias related to digitalis's enhanced vagal tone, such as sinus bradycardia, sinus arrest of AV or AV nodal blocks, tachyarrhythmias due to delayed after depolarization triggered activity, such as atrial, junctional, and ventricular tachycardia. Other than bidirectional VT, the other kind of VT digitalis can cause is VT with exit block. Non-paroxysmal junctional tachycardia is highly suggestive of digitalis excess in a patient who is taking digoxin, although other etiologies such as myocardial ischemia, recent cardiac surgery, and myocarditis should be excluded. The term non-paroxysmal refers to the gradual appearance and disappearance of this rhythm. AV dissociation occurs due to acceleration of the AV junctional pacemaker. AV dissociation that occurs in the course of digitalis therapy should be considered a sign of digitalis intoxication until proven otherwise. Digitalis causes PVCs commonly, but PVCs are extremely nonspecific. Although overt digitalis or digoxin toxicity usually occurs at serum levels exceeding 2.0 nanograms per milliliter, adverse drug effects may occur very well at lower levels, particularly if hypokalemia or hypomagnesemia is present. Digoxin toxicity does not correlate well with the serum digoxin levels and can occur all the time with normal or subtherapeutic levels, so the diagnosis is made on clinical presentation and ECG findings, more so than using the lab value. How about management of digoxin toxicity? It's treated with IV hydration. You can reach for digoxin-specific antibody or Fab fragments. These can be given if there are life-threatening cardiac arrhythmias such as advanced conduction block with junctional rhythm or end organ dysfunction with hypoperfusion or hyperkalemia more than 5.5. Digoxin toxicity causes hyperkalemia because digoxin causes excessive inhibition of the sodium-potassium ATPase in cardiac myocytes. Calcium gluconate and insulin, the usual medications for hyperkalemia, are actually not indicated in digoxin-related hyperkalemia and may lead to hypokalemia as therapy with Fab fragments rapidly lowers potassium levels. Hemodialysis is ineffective for digoxin toxicity because of digoxin's high molecular weight and large volume of distribution. Ventricular arrhythmias due to digoxin toxicity are treated with lidocaine. AV block due to digoxin toxicity is treated with atropine. You should try to avoid electrical cardioversion in patients with the digitalis toxicity, as the cardioversion can precipitate serious ventricular arrhythmias. That's all for atrial fibrillation part 1.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.